Good afternoon, everyone. Welcome to the 2025 Engagement Lounge webinar series presented by the Association of Neurovascular Clinicians. My name is Morgan Boyer, and I'll be moderating this session, How Stroke Coordinators Can Facilitate Change, a QI Methodology. ANVC is dedicated to the creation of seamless neurovascular care services led by evidence-empowered clinicians that fully support the holistic needs of patients and their families because stroke patients deserve nothing less. For more information about ANVC, please visit www.anvc.org and become a member today. We do have a few housekeeping items before we begin. This session is being recorded and will be available in the members only section of our ANVC website. However, only the viewers who attend this live session in its entirety will receive one continuing education hour. Viewers will receive an evaluation from Arizona State University. After completing and submitting the evaluation, participating viewers will receive a continuing education certificate. But again, you must attend the entire live session to be eligible. If you're joining the webinar today under a phone number or nickname, please enter your name in the chat or send an email to info@anvc.org in order to ensure you receive your evaluation for CE credit. Please feel free to enter any comments or questions into the chat throughout the presentation, and at the very end, we'll review these questions with our guest speakers. So now I am proud to introduce our guest speakers for this webinar, Joshua Adams and Melisse Maser. Joshua Adams is a nurse leader dedicated to improving patient safety, teamwork, and the care of experience. As a stroke coordinator, certified by our team here at ANVC, and a regulatory and accreditation specialist for Independence Health System, FIC, Latrobe, and Westmoreland hospitals. He combines data-driven insights with people-centered approach to help multidisciplinary teams deliver the best for the patients in each other. He also directs the Primary Stroke Center QA/PI initiatives and leads the facility's Joint Commission stroke care certification processes. Melisse Maser is a board-certified family nurse practitioner and advanced neurovascular nurse practitioner with extensive experience in stroke, neurology, and program management. She serves as a neurology service clinical coordinator at Butler Memorial Hospital, where she leads stroke quality improvement initiatives, guides stroke care certification processes, and provides advanced practice care for both inpatient and outpatient stroke populations. Thank you both for taking the time out of your day to share this information. The table is yours.
Well, thank you, Morgan, for the warm welcome and introductions. We're excited and honored to be presenting this information on behalf of our organization and the ANVC, and just share a little bit of our experience and journey together. We've got no relevant financial disclosures or conflicts of interest related to this subject matter. And this subject matter, what we hope to accomplish with you today over the next somewhat short of an hour, is to define the unique roles of stroke coordinators and understand how they act as educators, liaisons, and drivers of quality improvement in their organizations, describe a few key QI methods, and explain how they are applied in stroke programs. We'll analyze a case example to do this and talk about some strategies to sustain improvements, as well as ask you to commit to one small change in your practice or processes locally. We're going to begin here with a polling question. It should appear momentarily here. So if you are able to, with your mobile device, scan the QR code, and if not, we just ask that you put this information in the chat or Q&A function of Zoom. But we're trying to understand, what is your current experience level with formal QI methodology? Are you a novice with limited or no QI training? Are you a beginner who's had some skills, some exposure, maybe one or two internal workshops? Are you intermediate? Are you currently actively using various QI tools for projects, or are you advanced in that you lead the QI initiatives in your organization and train others? And I'm so excited to see that the Slido functionality is working, because I had some concerns about that earlier. Morgan, in the Q&A, it says chat is disabled. I'm not sure if that's something that you can fix, but give it another 20 or 30 seconds here on the Slido. Actually, what we're seeing here kind of is not surprising to me based on what I know about the caliber of ANVC members, but I was expecting a little more of a bell curve in terms of um, beginner, intermediate being the majority, and kind of novice and advanced being the outlier in the tails of the curve. But it looks like we've got a pretty good basis here for discussing some of these tools here, with the majority of our attendees here having intermediate experience level with formal QI methodology. So hopefully we'll be able to share some tips and tricks, a little bit about our journey once again. Um, but just to give you some introduction and background, I am, as Morgan introduced us, the stroke coordinator for 3 small community hospital primary stroke centers. I've had various clinical nursing leadership roles. Um, this role I've only really just stepped into over the past 5 years. So I kind of began it at the onset of COVID and have carried it through that time frame and beyond. I turn it over to Melissa to introduce herself and tell a little about her background.
Yes, and I just want to echo Josh's sentiment and thank you for having us on today. I did start as a bedside nurse, as many of you may have as well. I did work neurovascular intensive care for several years and have been connected to stroke throughout my career. I was in a traditional stroke program coordinator role previously. I still do oversee the stroke program, but in an advanced practice role. So we're happy to share with you some of our insights.
And how Melissa and I came to be connected is in 2023, our 2 smaller hospital systems combined to form what is currently Independence Health System in southwestern Pennsylvania. So again, we are all community hospitals. We're situated roughly 40 to 50 miles outside of Pittsburgh, as our farthest campus from Pittsburgh is Clarion Hospital, which is not currently a stroke center. However, Butler, Frick, Latrobe, and Westmoreland are all primary stroke centers, and we service a region that has about 750,000 covered lives in it. So it's a predominantly aging population. The need for high quality stroke care, both community driven primary stroke centers as well as comprehensive stroke centers in our urban center of Pittsburgh, is tremendous in our area. So of course we have to, discuss a little bit about why all this matters, and I'm quite sure that all of you are familiar with the prevalence statistics regarding stroke. Annually, over 795,000 new strokes in the United States. What you may not be as aware of are the projections for the next 5, 10, 15 years. So currently the projections from the statistical summary that's presented every year by AHA ASA show that by 2030, an additional 3.4 million Americans over 18 will have a stroke, which is actually a 20.5% increase from 2012. And again, I'm quite sure you're familiar with stroke being the leading cause of serious long-term disability, and a disease process where time-sensitive interventions are, in fact, very critical to outcomes. Having effective QA and PI processes enables us to meet our certification requirements that we hold, whether certified by ACHC, DNV, or Joint Commission, as well as meeting requirements for get with the guidelines reporting, whether optional or mandatory in your state. And the stroke coordinator role really is the individual or individuals within a system who bridge the QA/PI processes and clinical care and connect all of these things together. So as such, stroke coordinators are positioned as change agents in a complex, rapidly evolving healthcare environment. With that, we know we face a ton of challenges. Time is brain. All of our interventions are time sensitive, and we all are persevering towards meeting ever more stringent and tighter standards for door to needle or door to balloon targets. We have multiple disciplines and stakeholders involved in the care of a stroke patient, right? So it's not just the emergency department, it's EMS, pre-hospital, neurology, radiology, nursing, pharmacy, care coordination, to reflect just a few of the disciplines and departments that touch the stroke patient. We know that stroke clinicians are making life and death decisions that have long-term impacts to not only the individual, but the family and the community that they return to. And we have ever more stringent regulatory requirements, CMS quality metrics, state and federal reporting requirements. And last but not least, all of us seem to be doing more with less. However, that is underlined by the fact that without the adage, no margin, no mission is out there. So health systems, although by virtue are not money-making entities, we have to generate some revenue, and in order to do that, oftentimes it's a matter of keeping costs down. So our second polling question for the presentation today are: what are your biggest barriers to implementing QI initiatives in your stroke program? So we'll wait 30 seconds or so for responses. I guess I'm not surprised that this one isn't a bell curve. I am surprised that well, let's see, it just became neck and neck here. I was going to say I was surprised that the majority were experiencing a resistance to change from staff and physicians, but right now it's tied between that and limited time and resources. And when Melissa and I reflected in preparing for this, we were up there with the limited time and resources, as well as to a lesser extent, a lack of leadership support, because we all know our leaders are spread very thin as well. There are, especially in community hospital settings, there are directors or chief quality officers, service line directors, quality program directors that are overseeing multiple areas of responsibility. So not just the stroke program, but they could have the stroke program, sepsis measures, STEMI, primary heart attack center measures, even infection prevention. Our director oversees all of those and more in our hospital. Customer care, for instance, falls under my supervisor, my chief quality officer. So I really don't know how they do everything they do, but somehow we all manage to get by. So touching a little bit on the stroke coordinator's role specifically, we know that stroke coordinators, by virtue of all of the stakeholders that they touch and all of the things that they pull together for their stroke program are ideally positioned as change agents. We know, as self-reported from the audience here, that there are a lot of barriers and challenges to enacting those types of changes. Whether it's just straight up, I don't want to do it. We changed the way we did this last month or the year before that. Why isn't this good enough? There's the constant resource constraints, so we don't have the people, the equipment we need. There can be competing priorities among, is your stroke program rising above the needs of other programs, or just day-to-day issues within your hospital. We have frequent staff turnover. We have lack of physician engagement. Sometimes it's not often willful, but there can be situations where you have locums physicians or physicians that are getting burned out from their role and responsibilities and are just not as engaged as we would like them to be. And almost owing back to the original resistance to change, there can be cultural inertia. We've done this way for years. It was good enough in a previous time. Why do we have to change? I think it's interesting here, and I have this Wikipedia screenshot describing the linchpin, because there are numerous references that I've come across over the years in literature to the stroke coordinator as being a linchpin, and linchpin, linchpin, linchpin. I kept seeing this term repeatedly. And I'm like, well, I don't really know what a linchpin is. So, we think of the modern definition of it as someone who's vital to an enterprise or an organization's success. Like that forward is really the linchpin of her soccer team, or they're the individual that's holding together the parts or elements that really exist and need to function as a unit. But the original 13th century definition of a linchpin, which I think is really cool, is this thing you see there that's the pin that's positioned at the end of an axle, and it keeps the wheel in place. It keeps the wheel from falling off. And if you think about that in the context of being a stroke coordinator, that really is what we do in a lot of ways, is that we keep the wheels from falling off of the care processes. So now, what are our solutions to all of the problems and barriers that we face? So we come to the realization that systematic, data-driven quality improvement approaches are essential to our day-to-day work. And this is a frequently used phrase in the quality improvement work, is that everyone has at least two jobs in healthcare, right? I know many of us have many more hats, but we have at least two jobs, right? And they're to do the work and to improve how that work is being done. So in order to do that, we really need to move from reactive problem solving, the firefighting, to having proactive, structured improvement methodologies that use data to identify the opportunities, use proven frameworks for change, continuously and systematically engage all of the necessary stakeholders, and measure and sustain our improvements. And most importantly, and the ultimate goal, is to create a culture of continuous improvement. So we talk a little bit about frameworks here, and choosing and utilizing a QI framework can be somewhat daunting. There are a variety of them in the literature, and they overlap and complement one another in various ways. So sort of the three main frameworks that we're going to discuss and get into a little more today are the PDSA, or Plan, Do, Study, Act, or in some literature, PDCA, Plan, Do, Check, Act model, Lean, and Six Sigma. And some really fundamental principles of all QI frameworks, these three and others, is that they take a patient-centered approach. They are utilize data-informed, data-driven decision-making. They utilize a systems thinking mindset. So no stroke care is provided in a vacuum. It's all the different parts and pieces and how they interact with one another. And adopting a continuous mindset. And continuous is a word that I will use repeatedly because we often realize somewhat too late that quality improvement projects are not one and done solutions. We have to continue to keep them at the forefront of our work. So in just very brief summary, the PDSA cycles are rapid cycle improvements. They're small tests of change, tweaking a factor here or there, retesting it, and going about your improvement process there. Lean, in contrast, focuses on specifically eliminating waste in your processes and maximizing value for the patient or consumer. And Six Sigma is your statistical methodology, reducing variation and defects. And what underlies all of these frameworks as well are some of the principles of high reliability organizations. So high reliability organizations such as nuclear power plants, aircraft carriers, air traffic control are environments we know that are high stakes where a single error can have devastating outcomes, but they've also adopted this series of principles to hopefully reduce the risk or mitigate errors. And these principles include a preoccupation of failure, so always thinking about what can go wrong, a reluctance to simplify, really instead of just accepting that the first and simple answer is the correct one, making sure that you do a thorough analysis if it's a root cause analysis or a, a FMEA type analysis. You maintain sensitivity to operations, commitment to resilience, and deference to expertise. And expertise really means not the people up here, the ivory tower administrators or researchers or educators, but the expertise in a high reliability organization really is at the front line. It's the individuals who most importantly do the work and are at the so-called sharp end of the needle touching the patient. And I will hand over to Melissa.
For those of you with nursing backgrounds, you may remember the nursing novice to expert theory by Patricia Benner. So as a new nurse, we expected that we would be learning things along the way. We expected that we would have additional training, and we expected that there would be skills that we haven't yet developed yet. I think we need to take that same mindset and apply it to performance improvement and quality improvement. No matter what your clinical background is, my guess is that you haven't had any training or exposure to quality improvement until you move into that stroke program coordinator role. Of course, there's probably some exceptions, but the majority probably have no training background prior to starting their role. So that's okay. All of us learn along the way, and just to kind of step back and appreciate where you are and to grow from where you are and not to be frustrated by that experience. So to start building a skill set for quality improvement, we do need to develop some foundational knowledge and a good framework of the big picture of our organization. What is your organization's purpose? What is the stroke program's purpose? What is your individual purpose and role within the stroke care process in the quality department? If your organization has set defined mission, visions, and values, what are they? Are mission and values defined for your stroke program? Mission will set your framework for why your stroke program exists. Vision will set the overarching goal for what your stroke program aspires to achieve. Values outline the framework of how you will operate, and the target population keeps your focus on who you are serving. So this is more than just an exercise of creating a pretty document or, having a document to submit to a surveyor. This really is how you decide and keep focus on where the quality will be maintained, how to align your action steps, and how you will move forward with integrity. Because there's going to be challenges. At times, there may be confrontation or differences of agreement. There will be policy decision making, and you can easily get distracted and influenced and derailed by all the opportunities, potential things to do, all the things that maybe individual people or departments want. So having a good solid framework of what your mission, vision, and value is as an organization and at the stroke program will help keep you focused and aligned to move forward. So moving beyond the foundational framework of purpose, we also do need to have a good understanding of all the nuts and bolts that come together. I think one of the things that can be almost a negative influence is when you hear something being done really well at another organization and you get excited about that and you're like, well, let's do that here. And that can be very tempting to just go and do. But every organization is different in every hospital. And so there's some nuances of what worked well somewhere else may not work well at your own organization, and to really know your organization well before you suggest any performance improvements so that you can get as much buy-in as possible. So seek first to understand what all the departments are doing. How does your organization workflows work? Meet with people informally with no agenda to get to know people, to know their names, what they do. Look at reporting relationships, how resources are allocated, how communication and department goes between different areas. If you're a nurse, what is the experience like for the CT tech? What is it like for the ED physician? How do the neurologists function? What is the process for speech therapists and what they do? So that really sets up so as you plan with your teams that you are able to set realistic goals and potentially feasible action steps. One tool that you could use to kind of map out after you've met with people and spent some time learning processes is identifying strengths, spotting weaknesses, seeing opportunities, recognizing potential threats with a tool called the SWOT analysis to kind of map out things that you do well and to capitalize on that and to identify potential weaknesses or opportunities to be able to move forward with any quality initiative that you move forward with. And of course, no one does this alone. It takes an entire team of people. You'll want to embrace and connect with folks from across the whole breadth and continuum of stroke care. Some key stakeholders might be your administrative leaders, department managers, lead supervisors. You will want representatives and at a minimum points of contacts from every area that serves stroke patients. So even if they do not formally serve on a stroke committee, at least attempting to have a point of contact and an ad hoc from every area, even if it's a lower frequency, social work and case management, dietary, so that everybody knows the expectations and that you have expectations of relationship, that everyone is here to care for all of our patients well and to ensure that we are having stroke quality processes maintained. Considered gathering stroke champions. So these are not managers, they are not leaders, these are your frontline staff who have bedside advocates that are willing to support stroke care. I started as a traditional stroke coordinator role. Now I have different roles along the way after that, but in 2005, we actually had nursing reps from each unit, a physical therapist rep, a speech therapist rep and an occupational therapist. These were all stroke champions that were not in leadership in any way. Nursing, we've sort of lost our nursing stroke champions, but we still have 20 years later bedside PT, OT, and speech, and they serve faithfully on our stroke committee and our champions to make sure that we're delivering that well. So it really does make a difference. And lastly, be sure to include all your external relationships. EMS, we have 2 that serve faithfully on our stroke committee, but there's other relationships if you have telestroke partners, rehabs, skilled nursing. So trying to have all those connections and communications and collaborations in place, even if you have not set one single PI goal. I think a lot of just PI just begins with knowing each other and having points of contact to talk through things before you even set a formal PI goal. So you've got your collaborative team together, and so you've met with people, you've been talking to people, you've been understanding processes. We do really now need to move forward with actually setting a goal. So to do that, we do want to keep in mind a few core principles. The Institute of Medicine, now the National Academy of Medicine, defines 6 aims that should guide healthcare quality improvement. Our quality work should be safe, effective, people and patient-centered, timely, efficient, and equitable. The World Health Organization adds an additional 7th core principle, which is integrated, coordinating service, and avoiding fragmentation by connecting care throughout the community and the lifestyle or the lifespan. So you've got your core framework. You do need to pick what your QI methodology will be. So whether that's PDSA, Lean, Six Sigma, or another one that is out there. Now, this may be chosen for you, such as our organization. The organization has defined that everyone will use PDSA. Depending on where you work, you might have a choice. This can be overwhelming because we are stroke coordinators or over people in the stroke program leadership of quality. So we unlikely will have that expertise without additional training. So taking time to learn about these popular methods or spending time with someone who can be a quality mentor with you before choosing on a framework. Moving forward, we do need to look at stroke metrics. For stroke, a lot of this is already predefined. The American Stroke Association already has Get With the Guidelines, stroke achievement measures, quality measures, reporting measures, target stroke measures, target diabetes measures. There's so many measures within Get With the Guidelines. The certifying bodies, so Joint Commission, DNV, ACHC, they all have their predefined stroke performance measures that are required for stroke certification. Some of you may also be in state registries such as Paul Coverdell. CMS and Hospital Compare even have a few handful of stroke measures. So a lot of stroke is already predefined. So if you are new to stroke and stroke quality, I would stick with the predefined measures, and because everything is outlined. And then as you develop, you can take out PI projects to something that is more designed specific to you guys, or looking at data and fine tuning. I would consider that more of a advanced skill. So if you're new, sticking with the predefined measures and Get With the Guidelines. When I first started back in 2005 was much simpler of a data quality compared to today. And they've added so many measures over the years. So if this is brand new to you, it may be overwhelming. So I would only start with the achievement measures. So if you had to start somewhere, start with the Get With Guidelines achievement measures and then add from there as you go. You do need to have excellent metric competency and understanding how data is collected and where that comes from. So knowing the inclusion and criteria of who gets included into the metrics, who gets excluded and why, and what counts as an exclusion, know how abstraction guidelines work, where does that information come from, how is that documented in an EMR or another resource. It does not matter if you're the abstractor or not. Even if you're not the abstractor, you do need to understand how data is collected, where it is collected, and how and what gets included and what gets excluded, because you cannot improve what you do not understand. So we're going to spend a lot of time just simply thinking, learning, and understanding. And that is all before you even come to writing a performance statement. Once you have a good understanding, because we want to understand things well, because we don't want staff to be frustrated with things that are poorly designed, and we want to build sustaining over the long haul. If staff feel that you have the patient's best interest in mind and their best interest in mind, then they're more willing to adapt to change. There are times, though, I have had to say, there's nothing we can do about it. It's a quality metric. We just have to do it. So sometimes we do have that conversation too. We just simply have to do it, and the staff will eventually lean into that. So when we are writing our performance improvement goals, we want to be a very clear, defined goal. Using the SMART criteria can be a helpful guide. We want it to be specific, measurable, attainable, relevant, and time-based. So on the slide, I just share an example of one of our PI goals for this year. It was based on the American Stroke Association's hemorrhagic initiative, and this is what it is. At least 85% of patients with life-threatening intracerebral hemorrhage who were taking rivaroxaban, apixaban, or dabigatran prior to hospital arrival will be treated with the appropriate reversal agent within 60 minutes. And you can see that we have what we're trying to achieve specific, and on the written document we'll have the time frame that was to completed by the end of the year. You can add additional further clarifying statements, such as using the model for improvement 3 questions. You can also take the time to write stretch goals. So stretch goals are goals that are a little bit more ambitious. They may or may not be realistic, such as setting a performance goal of 100%. So kind of looking through and mapping that out. And if you've never done this before, I would definitely encourage you to seek out a quality mentor. And if you don't have that within your organization, I know there are many members at ANVC who have been here, have done that, and we would be willing to help guide you and fine-tune things if needed. After setting your aim statement, you will then begin utilizing your model. So whichever that is, PDSA, Lean Six Sigma, or another, and you will be planning and you will be implementing. So no matter which skill or method you are using, you do want to keep in the back of your mind some soft skills of project analysis. So I don't know that this is necessarily in, because I don't use Six Sigma, so I don't know what's in those in the details, but these are just some of the softer skills that may not be talked about that you need to consider, or we would recommend that you consider to help your journey in performance improvement. So naming barriers, so just name them so that you know it. You can work through challenges, whether that's IT or staff issues. Outlining secondary issues. It helps you identify poor performance. Is there a lack of skills? Are there training needs? Those things may not be apparently obvious. Tracking lessons learned. It helps you to remember what efforts worked and what doesn't work. This is good for your own skill development, to know how things worked in previous projects and using that knowledge to move forward. And even if you just keep a simple log that's only for you, that can help you along the way. Identifying impacts and outcomes. We're always so focused on the patients, but sometimes there are other really good impacts and outcomes that can be sustained momentum. And if you have already transitioned from alteplase to tenecteplase, that was a little bit of an easier win, right? Because we're making it easier for the nurse. We're going from a bolus to a drip to just a quick bolus. So sometimes there's other impacts and outcomes that, yes, our goal is patient care, but sometimes we can have win-wins in other areas, and that can help sustain momentum with staff for continuing to do quality for the long haul. And you also want to list out value, what matters and what doesn't. Unfortunately, sometimes there are metrics that are required, and it doesn't always make sense in the clinical world. Example of pushback for the longest time. As doctors would say, the patient has cardioembolic stroke. There is no atherosclerosis in the carotid arteries. Why do you want me to prescribe an intensive statin? And it's simply this: you don't have to prescribe an intensive statin if you feel there's no atherosclerosis and it's clearly cardioembolic, but you have to write it down. You have to say why you didn't prescribe it. And that's one of those things. There's no win-win there. You just have to write it down. Okay, and then looking forward of how you pull all this project analysis together is we recently implemented Rapid AI and CTP over the summer. We had a lot of technical issues, a lot of third-party issues. It was beyond enraging and infuriating with some of the back issues in the IT. And our CT tech kept saying, one team, one fight. And he would say it over and over again to keep us all aligned, that we are attacking the problem and not each other. So that, I think, that is an important value that I do want to remember for future projects, especially if the challenges are difficult, that we are together to fight the problem and not to attack each other. Moving on, as we implement action steps, we continue to collect data. You begin to analyze the data. You see what works, what doesn't work. There is a journey that I call accepting. You accept variation and outliers. There are just going to be those times and those special circumstances that are simply outside of our control, or the clinical case does not make sense for how the metric is written, and it's going to be a defect. You just simply accept that that is a defect and an outlier of the situation compared to how the metrics are written. And so dysphagia screening can sometimes be like that, of that you had someone who was clearly neuro intact by the time they came to the hospital. It doesn't make sense to the staff. The patient is no longer having stroke symptoms, but does have a stroke. So sometimes you just have to simply say, it is what it is. This is the process. Stroke patients are required to have dysphagia screening, even if they are not active symptoms. So it's just part of the journey of accepting that sometimes metrics may not always make sense to staff members. And there are going to be times that you have an unusual situation that creates an outlier. That's a lot to unpack in understanding variation and outliers. So much more than I could do here today. And I don't even know that I'm an expert on that by any means, but I do have some basics understanding. And one of the mentors that I had actually recommended and gave me this book. It's called Understanding Variation: The Key to Managing Chaos. It's by Donald J. Wheeler. It's a little bit of an older book. It's small. It's still in print. I would recommend this or something similar to help kind of understand variation and outliers for quality improvement. So hopefully you've been planning, you've been implementing, you've been looking at data results. You do want to start communicating those results. You want to pick something that is simple and succinct. I do know that Get With the Guidelines has reports built in it. Those can get very lengthy, especially if you're looking at multiple metrics, and they may not be easy for anyone and everyone to understand. You want something that no matter who they are, where they are, what department they came from, that they can understand this graph, because there are going to be staff who are part of stroke that they don't have statistics backgrounds or these high level, they're not going to know what a p-value is, or some of those things. So want something very, very simple that anyone can understand. So just a couple examples on the slide here of things that we have used through the years. In section 2, we had a simple metric name and we just had a symbol. We probably call these emojis today, but just a simple. A banner meant that it was good, and we had another symbol that meant that we weren't in compliance. In section 3 on the slide, you can see we have an A3 period. We used that for a short period of time. This was kind of busy, but it was quick. It had what the PI project was, the action steps, and a simple graph. An A3 just simply means anything that you can fit on an A3 size piece of paper, and that's it. Summarize the whole project and to post those. Because stroke has evolved and developed so much, and there's so many different metrics that we're monitoring and measuring, we primarily use the stoplight, green, yellow, and red, that you can quickly outline multiple measures, achievement measures on one slide, performance measures on another, red, yellow, green. Everybody can see how we're performing, and to be able to see how we're doing over the long haul without having to have a statistician background or spend a lengthy amount of time looking at it. And if you did see success and improvement, to make sure you're taking the time to recognize and celebrate that. I feel like so much time of staff, all we ever do is complain about the things that weren't done well, that we need to make sure that we're telling about the things that are going well, even if that's sustaining year after year, or something that seems trivial, to remind people of how that continues to make a difference and why that continues to matter. Recognition can maintain motivation and momentum, can reinforce good behaviors, and encourage continued participation. There are so many different ways that this can be done. I know that ANVC has talked about this in different webinars and on the discussion forums. So definitely log on and look at that, or even start a new discussion on all the different ways to recognize staff for their good efforts. Lastly, I just want to show you an example. This was my very first PDA that I did with a team. This is 2005. So stroke centers were, the only stroke center that existed back then was primary. It was a primary stroke center. That was the only thing. It was a new concept. The acute stroke ready and comprehensive hadn't even been developed yet. Our hospital had 0 stroke processes at that time. So we had nothing available except an article and 10 Joint Commission stroke performance measures that were proposed. And we began to, I was hired from the neuro ICU into this role. I had 0 stroke quality training, 0 knowledge in this. And so this is where we went. We put together this PDSA. We had an aimed statement, and our first project was dysphagia screening, because we had nothing in place for dysphagia screening back then. Now, if you look back, or if you would talk to me outside of here, I would say that this was one of our most successful projects, and I was very happy and pleased with the success of it. And still to this day, if someone talks to me about quality, I'm probably going to tell you this story about dysphagia screening. But if you look at the details, and if the screen might be blurry, that's okay. But this aim statement was vague. There was no set target or goal. There was no time frame identified, and I didn't know any better back then. We just had a bunch of passion. We wanted to improve stroke care, and we thought we were doing great. But if you look at it, it lacked polish. It did not have all those fine tuning, but we were still able to see improvement. So I just wanted to encourage you with that even if you feel that you don't have the knowledge, we were blind back there. We didn't know that we didn't have that knowledge, but we still made efforts and we were still able to see improvements. And I want to encourage you, no matter where you are in your journey, that even if you don't have it polished and perfect and you know all the details, that just simply wanting to improve care for stroke patients and making those relationships with other, that you are going to see improvement, even if the paperwork doesn't match what so and so or whatever says that you should. Okay, so I just want to encourage you in that. And I also have the graph here. So again, we started with nothing. The only things is sometimes it just so happened that a speech therapist saw, and that's how you had some beginning data. And I just want to point out that this took almost a year and a half to 2 years before we sustained momentum and change. And that's the other thing to keep in the back of your mind, that real performance improvement is going to take a lot of time, a lot of conversations, a lot of reinforcement, and it likely will take months, if not years, before you see sustaining change and not to be frustrated with that journey.
Yeah, and to piggyback off of that from my local experience with our three primary stroke centers in the South that I'm responsible for, our door to needle journey has been it has spanned my entire 5 years here. So when I began, we were just about 50% in door to needle 60 minutes or less. And um, the past 5 years have seen incremental improvements in that. Each year has been a subsequent improvement. There hasn't been a one silver bullet that has led to that change, but it's been the consistent, continuous, ongoing efforts of the entire team that has led to that improvement. So to sort of close things out here, I have a few QI project proposals. I was just asking for our audience what would have the greatest impact on your program right now? What type of issues are you struggling with? And if these are not applicable to you, I'd invite you to free text in the chat what you think your priority would be, or what you've already set as a priority for, based on, whether your PI plans are fiscal year from July of 25 to June of 26, or calendar year, what types of things you are dealing with. And I think unsurprisingly, a lot are still trying to improve those door to needle, door to groin times, because those are the ones that we are held to by our certifying bodies. Chat wise, Janelle has door to CT read, and I can identify and relate with that one, because we thought we had a solid process, we were doing well, and then lo and behold, we lost some of our full-time contingent of radiologists. So now we have to rely on after hours remote radiology. Um, Alicia, I apologize if that's incorrect, but dysphagia screening, that's again a challenge with my three sites. We thought we were pretty stellar in that regard, and then we switched from our prior screening tool to the Yale dysphagia screening, and with that change, saw an immediate drop in in our compliance, but it also illuminated, I think, for a lot of people, that maybe our compliance with the prior screening tool wasn't as reliable as we seem to think it was with the documentation. I like Amy's response: ICH management, reversal agent, and hypertension management. That's a big one right now for all types of stroke centers, whether primary or comprehensive. We're seeing that we need to hit those targets for reversal agents and hypertension management. And others with a variety of other responses. So it kind of depicts that each local organization, whether it's a single hospital or a small system or a larger system, um, quality improvement begins and ends at the front line. So it may go up the tiers of leadership to your your quality department director. their director or VP up to your board of trustees or board of directors, but ultimately it begins and ends at the local level and is, at the most important point is the patient and their family. So a few talking points on sustaining change, just to really re-emphasize the importance of leadership support and cultural integration in making changes that are, under the umbrella of performance improvement. Getting away from the mindset that this is a project and kind of transitioning to the mindset, well, this is, how we do things here. And again, everyone has at least two jobs in healthcare, the job that they're hired to do and improving the work that is done in their department. So achieving this through continuous monitoring, regular performance reviews, being open and transparent about what those measures are demonstrating. We can achieve this oftentimes with standardized protocols, regular audits, ongoing education, and being cognizant of and planning for staff transitions, because we know there is the turnover, there's the knowledge erosion that has occurred in various practice environments over the past few years, and we all also face competing priorities, resource constraints, and if you're lucky, like Melissa and I, you've survived a couple of organizational restructuring efforts as well. So last but not least, again, I just want to reemphasize, as stroke coordinators, you may not have a formal leader role in your organization, but you are leaders and you are catalysts for making measurable improvement that benefits your stroke patients. Having structured QI methodologies in your toolbox helps provide powerful tools for achieving results. There are a variety of ways to obtain this type of background and experience, but ultimately success requires a collaborative, systematic approach and your stakeholders being engaged and maintaining a sustained effort with that. So, and last but certainly not least, and this doesn't have to be what you replied in the chat or the poll, but we ask that you identify one process to review this month with your team and engage with them. And, again, if you're using PDSA or some other structured methodology, test that change and see what you can do to make a meaningful improvement for your patients, because as ANVC likes to proclaim, stroke patients deserve nothing less. These are a few of our key references there. I know in the chat someone had asked about the stroke statistical report. So that's the fourth bullet point. And that's the annual report from the journey or the journal circulation. Every year it's many hundreds of pages, but they do an excellent job of kind of compiling and updating the epidemiologic statistics around heart disease and stroke. And we also want to thank our Chief Quality Officer of our system, Mindy Dunkerley-Hildebrand. She allowed us to reuse some of her materials from a previous course that was taught when we had a more structured Office of Organizational Excellence. And then last but not least, a very, very sincere thank you to all of the members of ANVC, all of the leadership of ANVC, for your dedication to stroke care excellence.
Outstanding. Thank you both for your time today. It was really a fantastic presentation. I think it was very helpful for so many. Sadly, we are out of time, so I do encourage anyone that has questions and would like to pick their brains a little more to reach out on the emails provided here. And thank you everyone for attending today, and I hope you have a great rest of your day. Hope to see you next month at the ANVC conference. Take care, everyone. Thank you.